All right, let's get straight to it. Welcome to The Explainer. We're skipping the pleasantries today because we have a massive, high-yield clinical simulation to tear through. Our goal, complete mastery of complex cardiovascular pathologies by dissecting intricate mechanisms, discrete management steps, and those fatal clinical traps that separate rote memorization from true diagnostic excellence.
Here is the exact roadmap for our 3 diagnostic modules today. We're going to tackle the dynamic outflow kinetics of hypertrophic cardiomyopathy, the inspiratory hemodynamic collapse seen in cardiac tamponade, and finally, the deadly preload dependence of an inferior myocardial infarction. Let's jump in.
Module 1, HCM, specifically looking at dynamic outflow kinetics.
Visualize that asymmetric septal hypertrophy, driving a severe physical block right during systole. Notice how that massive thickening of the interventricular septum physically narrows the left ventricular outflow tract. But here's the kicker. It's not a static narrowing. High-velocity systolic flow actually pulls the anterior leaflet of the mitral valve right into the tract via the Bernoulli effect. So you get this dynamic obstruction that wildly fluctuates based entirely on how much blood is sitting in the ventricle.
Now, compare that dynamic state to a fixed obstruction, like aortic stenosis. This is a fascinating variance. Notice how manipulating left ventricular volume dictates completely opposite physiological responses. In a fixed obstruction, like aortic stenosis, more blood moving across the valve, say from squatting to increase venous return, makes the murmur louder. It makes sense, right? But HCM behaves in the exact opposite manner. If you squat, you increase preload, dilating that left ventricle. This physically pulls the septum and mitral leaflet apart, relieving the obstruction so the murmur actually gets softer. Conversely, if you decrease preload with a Valsalva maneuver, the ventricle shrinks, the physical obstruction worsens, and that murmur strictly intensifies.
So, let's put this into a classic presentation. We have an otherwise healthy young athlete with exertional syncope and a harsh systolic murmur. The absolute key here is that transitioning from squatting to standing abruptly pools blood in the legs, which drastically drops venous return. The ventricle shrinks, the dynamic obstruction clamps down, and the murmur intensifies. So how exactly do we treat this precise physiologic state?
The definitive strategy is that you must mandate beta blockers. You want to slow the heart, prolong diastolic filling, and strictly avoid preload-reducing agents. Let's exhaustively break down these distinct options. Option B, beta blockers, is your definitive answer. They exert a negative chronotropic effect, slowing the heart rate to allow more time for diastolic filling, which dilates the ventricle and relieves that outflow obstruction. But what about the noise? Option A, digoxin, is a positive inotrope. Increasing contractility here will actually worsen the dynamic outflow tract obstruction. Options C and D, nitroglycerin and loop diuretics, are preload-reducing agents. They will shrink the ventricle and literally trigger cardiovascular collapse in this patient. And option E, spironolactone? It's an aldosterone antagonist with absolutely no immediate role in the acute hemodynamic management of dynamic outflow obstruction.
Moving right along to Module 2, tamponade and inspiratory hemodynamic collapse.
Let's isolate an absolute diagnostic marker here. Pulsus paradoxus. This occurs when increased right-sided return physically bows the septum into the constrained left ventricle, plummeting your cardiac output. Now, this isn't just a slight fluctuation, it's a profound diagnostic hemodynamic shift. Think about it. During normal inspiration, negative intrathoracic pressure increases venous return to the right heart. Usually, the right ventricle simply expands outward to accommodate this. But in a rigid, constrained pericardial space, it has nowhere to go. So it expands inward, physically bowing the interventricular septum directly into the left ventricle. This abruptly chokes off left ventricular end diastolic volume, causing a massive, catastrophic drop in stroke volume and systemic blood pressure.
What's happening mechanically is the rapid accumulation of fluid in that inelastic sac abruptly drives interpericardial pressure way above right ventricular filling pressure. It's critical to note that it's not necessarily the absolute size of the effusion that matters, but the rapidity of accumulation that dictates the onset of tamponade physiology. When that interpericardial pressure spikes, it completely crushes the right atrium and ventricle during diastole, basically halting venous return. Clinically, this manifests as Beck's triad: severe hypotension, jugular venous distension, and muffled heart sounds.
Now, you will inevitably be faced with a patient exhibiting profound obstructive shock. Think severe hypotension and bulging neck veins. How do you instantly differentiate the source? You look at the lungs. In a tension pneumothorax, the massive buildup of intrapleural air crushes the lung, leading to unilaterally absent breath sounds and a deviated trachea. But in cardiac tamponade, the primary pathology is strictly localized to the pericardial sac. Therefore, the lungs remain completely clear, breath sounds are perfectly equal, and it's paired with that severe pulsus paradoxus we just analyzed. Let's process this scenario, layering a post-infarction complication directly onto our isolated markers. We have a patient who recently suffered an acute MI, now crashing into obstructive shock with hypotension and JVD. That 18 millimeter of mercury drop in systolic pressure upon inspiration, that is a definitive pulsus paradoxus. Combined with bilaterally equal breath sounds, we have completely ruled out a tension pneumothorax and isolated cardiac tamponade, which in this context is likely secondary to a post-MI ventricular free wall rupture. Bypassing any general stabilization, we must definitively select emergent pericardial synthesis to relieve the tamponade. Let's evaluate exactly why. Option C is the only definitive, life-saving intervention to drain the pericardial space and restore right ventricular filling. Option B, immediate chest tube placement. Well, that's the precise treatment for a tension pneumothorax, which we already ruled out using our long auscultation variants. Option A, endotracheal intubation, is a deadly trap here. Positive pressure ventilation will further decrease venous return and just accelerate cardiac arrest in a preload-starved tamponade patient. Option D, dopamine, is an inotrope that completely fails to address the physical fluid restriction. And option E, nitroglycerin, that will cause fatal venodilation in a patient already suffering from choked venous return.
Module 3. Inferior MI and preload dependence.
All right, there is a strict pharmacologic absolute we must respect here. Administering standard venodilators in right ventricular infarctions causes fatal hypotensive shock, period. The right ventricle is an inherently thin-walled, low-pressure system. When an inferior wall MI extends to involve the right ventricle, its contractility is suddenly decimated. The only way the heart can maintain forward flow across the pulmonary bed and into the left heart is by relying heavily on sheer venous pressure, or preload. If you administer a nitrate, you instantly dilate the venous system, completely dropping that crucial preload. The right ventricle fails completely, forward flow stops, and the patient's systemic blood pressure completely crashes.
This really highlights the clinical variance. Identical presentations of ischemic chest pain demand wildly divergent therapies based entirely on which ventricle is compromised. If a patient is having a massive anterior wall MI, the powerful left ventricle is failing. Blood backs up into the lungs, causing acute congestive heart failure and pulmonary edema. In that exact scenario, reducing preload with nitrates and diuretics is absolutely indicated to relieve the pulmonary congestion. But in an inferior wall MI, where the right ventricle is ischemic and highly preload dependent, those exact same medications must be strictly avoided because they will induce instant iatrogenic shock. Let's analyze this final case, where a standard algorithm application directly triggers a catastrophic iatrogenic collapse. The clinician appropriately identified acute coronary syndrome, sure, but failed to notice the specific inferior lead ST elevations before reflexively administering sublingual nitroglycerin. The clear lungs were a huge clue. Unlike a left-sided MI, a right-sided MI doesn't back blood up into the pulmonary bed. Now, thanks to the nitrate-induced venodilation, the patient is in profound shock at 70/40. What is the precise restorative intervention? Evaluating these 5 options, rapidly restoring venous return with isotonic IV fluids is the only correct answer. Option C is literally the lifesaver here. By pushing isotonic crystalloids, you physically refill the venous reservoir, overriding the nitrate's vasodilation and forcefully restoring right ventricular preload and forward flow. Let's eliminate the rest. Option A, metoprolol. It's a beta blocker that would further depress contractility and worsen the hypotension. It is strictly avoided in the acute phase of an inferior MI, especially if there's bradycardia or heart block. Option B, more nitroglycerin, would obviously just compound the exact error that caused the shock in the first place. Option D, furosemide, is a loop diuretic. It would deplete intravascular volume and absolutely guarantee a fatal outcome in this preload-dependent state. And option E, amiodarone, is an antiarrhythmic. It has absolutely no role in rescuing pure iatrogenic, obstructive-like shock. As we wrap up this explainer, I want you to ask yourself, are you merely memorizing algorithms, or are you mastering the absolute physiologic exceptions? We've seen today how decreasing preload can uniquely worsen a hypertrophic cardiomyopathy murmur, how a constrained pericardium physically chokes off stroke volume during inspiration, and how blindly applying standard ischemia protocols to an inferior MI can literally kill your patient. Understanding these mechanisms is the absolute difference between being average and achieving true clinical excellence. Keep pushing for that mastery, and I'll catch you in the next explainer.